Right, how's everybody doing? You need to stand up? Doing okay? All right, stretching. I'm gonna back us out a little bit to a large health perspective view, but very much echoing what we just heard, because that's what is happening in real life in our health system, which I will tell you about. So once again, I'm Beth Shank. I'm the Chief Environmental Stewardship Officer for Providence, which is a large health system with 51 hospitals, over 1,000 clinics, 120,000 caregivers. Those are employees. And you can start to read a little bit more about that. We serve in these states and India. And we have 2 hospitals in Montana over on the west side, that's St. Patrick and St. Joseph, but the bulk of our hospitals are along the West Coast. In large cities, we range from critical care access hospitals to large quaternary care hospitals in Seattle, Portland, LA. And it's really interesting work and very challenging because of, yeah, it's hard to make the things go, isn't it? Because of the challenge of healthcare. We're a Catholic healthcare system. And for us to be effective, we really have to anchor this to our mission. And these are the words of Pope Francis from 2015, who really helps do this in a mission-driven organization. This is one of my favorite quotes. You can read it yourself, but it really helps tie together our environmental crisis and our social crisis. Very important for linking this to mission, reminding people why we're doing this work, and ensuring that equity is at the center of everything we do and make decisions about. Just a little bit more of our background, which helps us when we talk about how do you make significant change in a large complex organization. It helps to have rudders, and this is a rudder. And these are words that were handed to us from the Sisters of Providence when they asked lay people to take over the management of the healthcare delivery network, hospitals and clinics. They said that we want to be good stewards of our people, our resources, and our earth. We ask that you demonstrate this as a model of good stewardship. We refer to these all the time in our health system to remind our caregivers why we and they care about it. We've been doing this a long time. Our earliest, we tried to track this down a few years ago, and our earliest recorded success was 1993. So that's over 30 years. And since then, things have slowly, it's taken a long time. You can imagine what the anesthesiologists were just saying about the slow rate of change. And earlier, even 5 years ago, this was not as much on people's minds. But the evidence is irrefutable. The lived experience that we're all seeing about climate and about our planetary health crisis writ large is really undeniable. I believe that somehow, and I was speaking with someone about this, the pandemic allowed us to pause a moment because things started to shift after that related to climate and healthcare. And now what we see is just a lot of coalescing amongst national groups, which I'll tell you a little bit more about. So I'm going to just say we've made a bold goal to do everything we can to reduce greenhouse gas emissions by 2030. This is because the scientists have made it clear that this decade is really important. Every day that we don't make progress, we're making it worse for the future. And so we still have a chance to really make significant progress, and many, many people around the world are working on this, and so are we. Just for terminology, and Dr. Piotra explained this in terms of the global warming potential. So I just want to make a quick note that the reason we call it all carbon is because we make this conversion to a carbon dioxide equivalent based on the length of time in the atmosphere and the intensity or the global warming potential of the chemical. Those big bubbles up there are the biggest groups of greenhouse gas emissions, and we translate that to an equivalent of carbon dioxide. MT CO2e is metric ton. I say this because it's the language of climate work. And we need, in our health system, we're trying to educate more people about that. So I just want you all to know that that's the common phrase, MT CO2e. And along the bottom, you can see just the greenhouse gas emissions by sector. So we're addressing each of those. This is just an image of the greenhouse gas protocol, which I won't go into too much. Really interesting. But I do want to point out this. We have done our full carbon assessment of all 3 scopes, and we have found in Providence that A fairly small amount is scope 1. That's the stuff that goes out of our smokestacks, including nitrous oxide and the desflurane, also natural gas. And then in scope 2, the orange is our purchased electricity and steam, and everything else is in scope 3. That's the products we use. That's why the plastics discussion is important. That's our business travel. That's our capital equipment for buildings. That's our waste. That's investments. So it's a big, big bucket that really is the bulk of greenhouse gas emissions in the world and in healthcare. So when we say, scientists have said that 8.5% of US greenhouse gases are from healthcare, it's the whole wheel here. It's not just what's going out of our smokestack. When we say that 4.5% of global emissions are from healthcare, it's the whole wheel. So it's complex. Now, this is just a view of our overall strategic plan. And I bring it up because you may be familiar with terms in climate work of mitigation, adaptation, and advocacy. That's a common framework that is used by different organizations. Mitigation is driving down greenhouse gases, preventing further harm. Adaptation is dealing with the changes that are here now, adjusting, preparing, and responding. And advocacy is using the power of our voices to help drive better change, a better future, essentially. So I'm going to take a few minutes to go through each of these, but I want to pause and say, is there something that you'd really like to know about healthcare, hospital, particularly in clinic, environmental stewardship that I want to make sure that I capture? Anything that anybody wants to throw out? Hard to say without knowing what I'm going to say. All right, I'm going to blaze through, but I would like you to interrupt me if you have a question, because I'm shortening this. This is the mnemonic that we have developed to guide us in mitigation. That stands for the biggest buckets of greenhouse gases: waste, energy and water, agriculture, food, chemicals, and transportation. We work in each category to great depth as we are measuring and tracking the emissions decreases that happen every year. Waste, really complex in healthcare. As Piotr was saying, we in Providence last year, 94 million pounds of waste, kind of astonishing. Probably about 70 million that was disposed. So we think of our waste in these categories: what goes actually out the door to landfill, autoclave, or incineration, that's disposed. What could we pull out of the waste stream to keep it from going there for a better, higher value use? You can see some listed there: compost, recycling, universal waste, etc. But the most important and the hardest to deal with is the green, and that's the avoided waste, or the waste we don't create in the first place. This would be through reusable products like the LMA, or through making better purchasing decisions, or for redoing surgical kits. There's lots and lots of ways to avoid waste in the first place. And this is important because of what I said before about scope 3. The biggest piece of our scope 3 emissions is what we purchase. So if we can purchase less, use it more efficiently, and study that in ways that we can measure it, that, I believe, is a good solution. So that's what we're doing. It's not easy, but we do that because we track at every hospital, 51 of them, every month since January 2019, over 20 waste streams: the pounds, the cost, and the carbon emissions. So we have a real in-depth understanding of these different patterns of sources of these materials, where they're going, and what it means to us for our carbon and cost. Energy and water, you may be quite familiar with this, because oftentimes what I find in healthcare, when I start talking about environmental stewardship, they say, oh, you deal with recycling? I say, well, I do, that is one thing, but there are about 50 things. Another thing that gets a lot of attention in environmental stewardship is solar panels, right? I look at our friends from Amoresco. And so that's great, and it's really important. And we're working hard on our energy in a few ways. Energy efficiency is the most important, I would say, because that's the least expensive way to cut carbon and to save costs. It's sometimes hard in older buildings that were built in the 1960s, but we work very hard at that through deep energy retrofits. We're doing a major LED lighting project right now across all of our states, etc. However, we also need to get less polluting sources. That's hard to do, especially directly. For instance, we have a hospital in Washington State, Centralia, Washington, that has the largest solar array on a hospital in the state's history. It's significant. And it generates less than 1% of that hospital's electricity needs. That's just, it's so energy intensive. So it's not really practical for us to do direct energy generation. We're not energy companies. So we work with our utilities for purchasing renewable energy credits, for partnering on PPAs, power purchase agreements. We're working now on our VPPAs, virtual power purchase agreements, so that we can at least get credit for and claim, it's a complicated discussion about electrons, those renewable sources for our purposes. That's great. On the other hand, we have a bigger challenge with our natural gas. We're dependent on natural gas. We're mostly, a lot of our sites are in the north. Really hard to decarbonize a hospital from its natural gas. I was speaking with folks earlier that we're doing that study right now with the American Hospital Association, American Society of Hospital Engineers, and the Department of Energy to really look at the details of what does that mean? How would we do that in a hospital while the hospital is functioning? So we'll be presenting that at CleanMed next month for the first time, and are excited to share that with by then we will have a cost estimate. It will not be cheap, but it will be a lot less expensive than building a new hospital. Yeah.
Is there any thoughts about less air conditioning in hospitals? I mean, I am always freezing year-round in hospitals.
Yeah. The question was about air conditioning in hospitals. So HVAC, or heating, ventilation, air conditioning, is the biggest user of energy. Lighting is second. And it's a big concern because in healthcare, some of the hospital needs to be cool, operating rooms, procedural areas, some needs to be warm. Everybody feels differently about it. Nursing staff, patients, everybody who comes through, has specific needs. It's pretty challenging to manage. We also do a lot of heating, cooling, and reheating while doing 7 to 20 air exchanges per hour. So that's why hospitals are 2.5 times as energy intensive as other buildings. That's one reason. So, I think that has a lot to do with how well we can control the space and the comfort level. And some of that's required. There are requirements. And then the next opportunity is in modernization of the buildings so that we can have more computerized feedback and digital controlling from a central place where you could say, oh, in this room, we need to go down 1/10 of a degree. It's not easy, but yes, people do look at that. Water is also a big concern, especially in our drought-ridden states. I'm going to just keep moving if I can move it. I understand what you guys were saying about this. Agriculture and food. This is also a big deal. It's a significant part of our emissions in the world and in the US and in healthcare. And it's thought that about 10%, 8 to 12% of healthcare waste is food waste. So we are working on that too. We're working on decreasing the carbon intensity of meals served. That's primarily by moving toward more plant-forward foods, but it's also in the menu planning, less food waste, etc. We also work on compost everywhere. We have the benefit of having it be mandatory in California and Washington. Have to compost. It's great because then we can demonstrate you can compost anywhere. Basically, you can compost anywhere. Also working on food packaging, which is hard. That one we really backslid on during the pandemic, and that's been difficult, but we have a task force that's working on that at all of our hospitals. 30 of our hospitals right now have signed up for the Cool Food Pledge, which is a great opportunity for anyone who's in healthcare. It's offered through Healthcare Without Harm, and it measures and reports emissions based on food purchases each year. Next is chemicals. And you've heard a great review of chemicals in terms of the anesthetic agents and some of the pharmaceuticals. Dr. Brian Cheesebro, who Piotr mentioned, is our medical director. He has done that work for Providence. And so similarly, been working on those same issues. We are about to announce, I hope it's in April, but it might be later in Q2, that desflurane will be off of our formulary. And also we have a very studied and practiced approach for disconnecting our nitrous systems. We'll be releasing our first nitrous disconnecting toolkit on April 29th. So if you want to keep that in mind, you'll be able to check our website for that. As of yesterday, because we're reporting out next week, 52% of our hospitals have done that. So over half of our 51 hospitals have gotten through the shift from piped nitrous systems to the cylinders. We also worry about chemicals of concern. We know that healthcare staff are more exposed to occupational chemicals than others. And that's because of cleaning chemicals, pharmaceuticals, the materials that we open constantly, plastic exposure, et cetera. So that's really hard. That's a really hard one. But we work on that through education and through encouraging proper protection and others. And the T for transportation is also really hard because we're still dependent on our single occupancy fossil fuel run vehicles. And we have 120,000 people who drive to work every day. That's our biggest source, is employee commuting, as it is for almost any business. We also work on our business travel. And again, that was helped by the pandemic as people started to learn we can meet virtually. We can do a lot virtually. We have a remote work program. We have about 15% of our staff who work remotely. That's helpful. And we also work with our supply chain on delivery efficiency, on using the EPA smart way mechanisms for using less fuel. One of our primary distributor, Medline, is also testing electric vehicles and trucks, big semi trucks. Yes, ma'am.
I have a question from the chat. Are you working with local growers at your locations in Montana?
Yes, we are, and across the whole health system. So the question was, are we working with local growers? We have an extensive scorecard, which I'm going to show you, and we track the percent sustainable measured by a number of different groups that are nationally regarded and local. And that's a 250-mile radius. And so we do track that. Local is not so easy, I have to say. It's easy in some parts of our country, for instance, in California, because most of the produce is local there. In other places where it's harder to grow, the things that count as local are bread, some local things. In Montana, we've been successful with legumes and onions, but it's not so easy because of serving 5 million meals a year. I mentioned data. So we have had the great fortune of working with our team in India to build the WEAC scorecard. And in this, we've been able to track for a long period of time, now 5 years, all of those elements I was mentioning to you. And that lets us know how we're doing in terms of resource consumption or waste production, what's the cost, and what are the carbon emissions. We also normalize those data by square foot, by FTE, by, that's usually the two, APD, adjusted patient day. So we can stack the performance amongst our hospitals. This is really helpful for motivation, but it's also helpful to let us know, well, what in the heck is a benchmark? Because this is not studied stuff around the country or the world. So I am of the mind that with our data now, with the 51 hospitals, with this robust database, we're starting to be able to ask questions of what does it mean? And what does it mean if we change X%? And what will that mean in 2 years? So we're starting to build in some forecasting into our database, which is really interesting. If you love data, you would absolutely love this. However, most people don't love data and they don't like to look at sheets of numbers. So we've developed a simplified 10-point feature here called the WEAC profile score, which identifies 10 important but not exclusive areas of concern. They're weighted according to how important they are. And then we have scores for every hospital or region or system every quarter. So this has been a real helpful game changer because people can suddenly see, they can just look at the colors and say, oh, what's that red? I need to be green. They can see their number, which this number is 49.5. I want to get to 100. We believe everybody can get to 100. That's our goal. So using data effectively is challenging, and we're making some progress. We also really work on our purchasing. As I mentioned to you, I'm not going to go into this a lot, but we have criteria for what we purchase. It doesn't mean every single thing is perfect, but it gives some guidance to the several thousand people who purchase stuff every year. I do want to talk about this a bit. This is our resilience work. So the Department of Health and Human Services put out the Climate Health Pledge a few years ago, and we were eager to join. And one of the requirements was a climate resilience plan in 2023. So we did a lot to wrap our heads around this. What does it mean for a health system? What does it mean for providers? What does it mean for community members? And we're talking about how do we change how we deliver care in the face of climate change? What happens when it's 116 degrees in Portland, as it was in 2021, when several thousand people died? And when our building, large hospital, St. Vincent, but on a big south-facing area, the window frames and door jambs warped. It was that hot that it was almost melting the building. What do we do about that? So we are looking at our resilience work in 3 ways. One is the buildings. How can we make sure that they can keep things cool? Because air conditioning is different when it's 116 degrees. We were struggling to keep the buildings cool. You have to have buildings be safe. Also, we're looking at clinical care. What do clinicians need to know to do differently? What do they need for education materials? What do they need for data and evidence? What do they need for new available resources? We're working in some really interesting ways with AI, with our EHR, that's the electronic health record, to make some points of entry that are easy to access. So you can identify with a click what diagnoses or what groups are impacted by heat-related illness. What can we do about that? So it's really complex. And then the third pillar of this is working with our communities, which we have done for many years and will continue to do. That's why we're here, is community service. So helping to support those organizations that are working toward resilience, and also helping with education for safety. Always with equity and environmental justice as the primary driver here. And I'm almost finished because I'm almost out of time, but our third piece about advocacy, this is really important for a group like this, because we as healthcare professionals have both a moral obligation and a powerful voice. I plea always for us to be able to understand enough of what we need to be able to speak well and clearly about this crisis. One of the things I do on the side is some research at Washington State University, and we have the CHANT tool, which is the climate and health tool. And I know from that, having done this, used this since 2019, that when health professionals are asked how often they speak with friends and family about climate and health, and these are people who are mostly interested in climate and health, that's how they found the survey, it's fairly regularly. When you ask about how often they do that with colleagues, it's occasionally, like a few times a year. When you ask how often they do that with elected officials, by far the most common answer is never. And almost the entire rest of the answers are rarely. We can't do that. We really know something about health and climate, and this is an opportunity. I do want to say, this has been really exciting because I've been doing this work for about 30 years. And this is really wonderful. I don't know if this makes any sense because these are all acronyms, but this to me is a sea change. These are the leading healthcare agencies and organizations who are on board with concern about climate and health. The Joint Commission, for instance, just put out their first certification for healthcare sustainability. Just on Thursday, 2 days ago, CMS announced theirs. We've been waiting on that. We've been speaking with CMS. That's Center for Medicaid and Medicare Services. Amazing. AHRQ, the National Academy of Medicine. So many bodies are now working on this. But what that means for us, people in the field, it's us who get it done. It's us who really gets this work done. So I'm thrilled that all of you are here today to learn more, maybe learn from each other, do some networking, and I'd be happy to talk with you later, but I need to hand this back over to Lori. So thank you so much.